At this time, it's my pleasure to introduce Megan Farley, PhD. Megan Farley is a lead clinician working with families of teens and young adults with autism spectrum disorder, ASD, through the Transitioning Together program. Developed at the Waisman Center under the direction of Leanne Smith, PhD, Transitioning Together is an 8-week group intervention where teens with ASD meet as a group while their parents meet together separately. Families focus their efforts on understanding important information about transition while also practicing to support their sons and daughters on the way to adulthood. Megan, at this time I'll turn it over to you and we'll head on with the presentation.
All right, thanks, Maya. I'm really happy to have a chance to share information with you all about the Transitioning Together program that was developed here at the Waisman Center by Leanne Smith and a number of her colleagues. I have had the opportunity to learn from Leanne and be the first clinician here in our clinics to run the group in a clinical capacity. So those are some of the things that have come out of research here, a whole body of robust longitudinal research at the Waisman Center about people with autism spectrum disorders. So Leanne Smith developed Transitioning Together out of the recognition that there really are very few supports available to families during this stressful period. The program is very much informed by the findings of this body of research that's accumulated over the past 20 years. And I just want to take this opportunity to note that Transitioning Together is not a support group. It's a group that's designed to help families gain knowledge and learn new skills to be more effective supports for their teens and young adults as they move further into adulthood. So Leanne and her team began developing the program with the background of accumulated research, but then they also convened focus groups of parents of youth with autism spectrum disorders to get their thoughts on what they felt would be most helpful to them. And families indicated that they would like to know more about a number of topics, including communication, legal issues, safety, futures planning, self-care and family care, college programs, and dating. They asked for some specific needs, and so they're looking for real solutions, help with advocacy, resources and referrals, and then community activities and connections. And the families also offered ideas about how to execute a program. So they were really looking for activities for their teens. They thought it'd be helpful to have snacks, and indeed it is. They thought it'd be helpful to individualize the program to families, to involve college kids, making it kind of more attractive for the young adults and teens to participate, and then to use technology also in the program. The overarching goals for Transitioning Together are to provide education and support for parents, to provide opportunities for social interaction and learning for the adolescents, and to emphasize positivity and problem solving. I should just mention at this time that sort of, in talking with Leanne, she noted that this program sort of began with a focus on parents, and that the kind of the teen and young adult part was sort of a later addition in response to parents saying, we're all going to be together. Wouldn't it be great if our teens were able to get together as well? So a lot of the manualized approach is really focused more on the parent component with a lot more flexibility involved with what the teens are doing during this time. Okay. So components for the Transitioning Together program include 1 or 2 family joining sessions. And joining sessions are a time for one of the adult group facilitators and one of the teen group facilitators to get together with the individual family and to get to know the parents and the family story while also getting to know the teen, usually sort of, somewhat together and then also as little separate dyads. And so in the joining session, we're getting to know, what are the family's concerns? When did all this start? What kinds they encountered in the community, what sorts of things do they feel that they've been missing over time. And so in doing these joining sessions, we are able to sort of build an alliance with the family and let them know that we really care about them as individuals. And we're also able to find out what some of their specific challenges are and some of their unique needs are, and that helps us to be better prepared when bringing the whole group together in doing some of the activities that I'll describe later on. Helps us know what sorts of things we won't be able to provide to the family that they need, and to be able to make some referrals for them as soon as possible. So in addition to those joining sessions that occur before the groups start, we have these 8 weekly multi-family group sessions for the parents. So the parents all get together one night a week for about 90 minutes a week, over 8 weeks. And then at the same time, we have this sort of therapeutic group for the teens that's occurring in the same building but in a different location. And so the parent group includes a facilitator and sort of like a support person. It could be another therapist or another staff person, or it could be a graduate student. And then like an advanced graduate student in the related services field. And then the teen group usually includes a clinical therapist of some kind, and then 3 or 4 graduate students. And we're so fortunate, of course, in this context to have access to a number of really enthusiastic and bright graduate students who are really happy to have the opportunity to participate in these groups, and that provide some really lovely social models for the teens, and are really, really positive in their interactions with them. So we're in a really good situation. I just want to acknowledge that, and not everyone has that available to them, but that's sort of how we run the program here in our clinic. An important part of the program is also to offer ongoing resources and referrals to the families throughout the course of the group. So lots of times we'll have kind of a number of people who have their ear to the ground on things that may be interesting to the families, and so we can bring in community activities that'll be happening that may be of interest to folks, or if a question comes up from a family member about accessing some sort of service, and we're able to oftentimes help them out right away. Yes. Yeah. Thank you for Susan for letting us know that it's hard to hear sometimes. I really appreciate that. I'll snuggle up to the phone. So another thing that we have begun to do in our clinics here is to offer kind of ongoing groups for families. They're sort of like booster sessions, just once a month, and we're still kind of trying to figure out where the sweet spot is for that, to have families participating, but maybe not becoming dependent on this particular service. Okay, so based largely on the feedback of families during the focus groups, but also on the expertise of the program developers in sort of studying autism in adolescents and young adults, the parent session topics include different topics for each week. So there's autism in adulthood, transition planning, which really involves having someone come from the Division of Vocational Rehabilitation to talk through how to access services and what people can reasonably expect, and what DVR is not able to provide to them. We talk about family dynamics and what we know from research about how families of folks with autism spectrum disorders sort of grow and develop together over time. We do this therapeutic problem-solving strategy session, and I'll describe that in more detail in the coming slides. We also talk about risks to adult independence for people with autism spectrum disorders, community involvement, how to get involved and engaged, and maybe create situations that aren't readily available to the family. Risks to parental health and well-being. And then we also have a legal issues session, which is wonderful. We have an attorney who specializes in this area who's able to come and speak with the families and answer a lot of their questions on the fly, which is a really, really popular and valuable experience for them. And the teen group is really lovely. It has traditionally not been so much a didactic experience for the teens as it has been. I mean, there's definitely a didactic component where the teens are learning about conversational skills and how to use nonverbal communication and that sort of thing. But I think that the tremendous value that comes from this group is as a corrective social experience for these young men and women who very often have not had positive peer interactions and maybe who don't have friends, but at this time in their lives are really looking for friends. So just like anybody else, these teens, well, I don't know, just like me, I guess, and many other people, these teens, they come to the group and they're really nervous about participating in a new group of people, and they don't know what it's going to be like, and, they're not really the ones that are signing up for this. Their parents are signing them up. And so they're apprehensive and not terribly enthusiastic in general. And over again, by the end of the group, the kids, I've seen kids cry because they don't want it to be over, and they just love the group so much by the end. It's really amazing. And I think a lot of that has to do with the positivity and kind of the high, college student to participant ratio. It just ends up being a bunch of human beings hanging out and sort of having a positive time, and everybody working to create, all the adults working to create a really safe space for the teens. And through that, there are a lot of therapeutic benefits. We've seen kids who were unable to really talk in a group of people be able to talk and even dance by the end of our group. So it's really been a phenomenal experience. But there's a really routine process for each of the teen groups. They come and they have kind of a pros and cons of their week type of a turn-taking experience. They do a little bit of a didactic session, and that didactic session can involve goal setting, problem solving, social communication, those sorts of things. And then they will do a lot of sort of positive social things like playing games together. And it's really neat because in the last 2 sessions they do planning for an 8th week party, and in the 8th week they have a party together that they have planned and executed, and they get a little budget to deal with and that sort of thing. So it's really a terrific experience. Sorry, I go on and on. It's just have really positive feelings about it. So, and you're a captive audience. All right. So while the program includes the didactic content that I talked about, and I'm coming back here largely to the parent group, so it includes the didactic content that I talked about before, but there are 2 major thrusts of the program that occur throughout all of the interactions that a clinician has with the families. One is the notion of positivity. So a major subfocus of the research on the transition to adulthood in the family context that people here at the Waisman Center have done has been on expressed emotion in the family context. So this idea of expressed emotion came out of research on people who had pretty severe psychiatric conditions. And so the idea of expressed emotion is related to emotional intensity that's usually negative and also is often related to enmeshment or over-identification that a family member may have with the person who has the psychiatric condition. And this kind of negative emotional intensity has been associated with a worsening of symptoms for people who have other conditions. So in taking a look at this notion of expressed emotion or sort of negative emotional intensity over the course of months or years in samples of youth and young adults with autism spectrum disorders, the research team here at the Waisman Center found that higher levels of maternal warmth or positive remarks are associated with lower levels of behavioral problems. And then when there are higher levels of maternal criticism or this sort of expressed emotional intensity, expressed emotion, they see an increased severity of internalizing symptoms or things like depression and anxiety, sort of self-directed psychiatric problems. They also see a worsening of behavior problems and an increase in the severity of autism symptoms. And so this was really carefully done in a number of different studies that were looking at this question from a number of different ways, including longitudinal examination of this situation, and this has been borne out pretty consistently throughout the research studies that they've done. So positivity is a really big deal, and that's no surprise. Like, we've known that for a really long time, but it was interesting to see how consistently it was demonstrated to yield an increase in behavioral challenges and autism spectrum disorders in people with autism spectrum disorders. Um, so the way that positivity then is sort of used in the Transitioning Together program is to maintain a positive, solution-focused approach at all times, to demonstrate positive regard for the parents and the unique challenges that they face, knowing that they aren't just parents of somebody with autism, but they're also individual human beings themselves, to maintain a strengths-based attitude and vision of the teens and their parents, and to use humor when appropriate to create an atmosphere of positive sharing around difficult issues. So the goal with this is never to be fake in being positive or Pollyannish, but to look for strengths that the family is able to demonstrate or is sort of, alluding to in talking about a challenge, to positively reframe situations, to find workable solutions to problems, and to find those workable solutions even though the solution may yield only a tiny step in a direction to help a family get unstuck in the situation that they're in. So positivity is a major focus throughout all of the clinicians' encounters with the family. Another major thrust of the group is on problem solving. Developing strategies for solving and practicing the strategies with these families is helpful in supporting the families to see themselves as efficacious in tackling problems in their lives. It's about trying to help families get a little movement so that they can get out of being stuck in a problem. So the specific approach that is used in Transitioning Together was selected because of its success with families where there's a member who has a significant psychiatric illness. And this process offers people the opportunity to really slow down in their efforts to sort of respond to a problem. So they're able to identify the specific nature of a problem and then to generate plausible solutions. And then when you bring together other families into this process, individual families get to have the experience of having their own difficult experiences validated, as well as having the opportunity to see how other people have been successful in different areas of their lives. And as I'm sure you can imagine and have experienced, families often have the best solutions to offer one another when it comes to the realities of tackling a real life problem. We're also often able to spot faulty thinking or problematic behavior in other people more easily than we're able to see it in ourselves. And a lot of times, sort of families are able to come together in a really gentle way and help each other recognize some of the things that they're bringing to a challenging situation. And then just like any other brainstorming process, in this problem-solving process, all solutions are equally valid and valuable. Okay, so just like a nuts and bolts thing, when we're doing this, we use a really big easel paper and markers, so it's not like a really sort of technologically sexy approach, but it works, it gets the job done. So we put this paper up on the wall, and the sort of backup clinician in the adult group takes notes of the identified problem and the solutions that participants offer. So the first step is to work with the family to identify the problem. And we know that kind of the more we get down to isolating the problem in specific detail, the more likely we are to generate productive solutions that will yield a positive outcome. So for example, if a family says, he doesn't follow directions, we can then perhaps get to bringing out a specific solution that's problematic, which could be something like, he doesn't get up in the morning when I tell him he has to so that he won't be late for school. I'm sure that you can see that it'd be much more realistic to come up with possible steps to get a little bit of change in the problem statement about not getting up in the morning compared to the problem statement, he doesn't follow directions. That's a really hard thing to kind of sink your teeth into. So we define the problem with the family. And the next step is to generate and list on the paper so that the families can see it all of the possible solutions for the problem that the families can come up with. And we try to honor the family and what they're, each of the families and what they're contributing by really keeping to what the family describes and the words that they use when they're offering a solution. I think, like lots of times, we have a tendency to kind of want to summarize things or restate things in a way that we think is a little bit better than the way that the family said it. But it's really important to kind of honor what they contributed and to write what they said. So we write down all the possible solutions, and just as I noted in describing this before, this is really a typical brainstorming approach where all suggestions are equally valued and viable at this point. So in the third step, the target family or families, so like the people who came with this problem and who isolated this problem, will go through each of the suggested solutions, describing what the pros and cons are of each of the solutions. And then finally, in the fourth step, the family identifies a solution or a combination of ideas that they're willing to try over the next week, with the understanding that they will report back to the group on how it went. So this problem-solving process is something that we do in 5 of the 8 weeks, and that gives the families a chance to practice this approach several times. I also want to just let you know that the facilitators of the parent group collect all of the suggestions, and then each time that we do this, we'll prepare a handout for the family and then pass those back to the family at the next meeting so that everybody at the end of the group leaves having this like a set of suggestions for at least 5 different problems that are probably going to be things that will happen for many people in their lives. Okay, so that's kind of the nuts and bolts of the problem-solving process, and then positivity occurs throughout the group. We have a didactic component for the parent groups, didactic component for the teen group, and then, kind of a really positive, corrective social experience for the teens. So not too long ago, Leanne Smith's team completed a randomized waitlist control study for this intervention that included 45 families of teens. And those folks were aged 14 to 17 years. So the families in the intervention group demonstrated improvements in the adolescent social engagement, improvements in parental problem solving and attitudes about their children, and reduction in parental depressive symptoms over time. So some pretty nice results for relatively low cost, low intensity intervention. And then I just want to finish with some of the comments that families shared upon participating in the group. So one parent said, "At times with my son, I felt very isolated and alone. Hearing other families talk about having the same types of experiences was really validating," and that's something we hear from a lot of families who oftentimes have a difficult time finding families who have teens and young adults who have similar functional ability levels. Another comment was, "It gave me a wealth of information about what should have been going on at school as far as transitioning." And another said, "I wish transitioning together was required for every student."
There's a Facebook listing for it.
The teens contributed comments like pretty much all of us had some sort of interest that people usually don't. It was really cool. We could share our ideas on these like weird topics.
It's really nice. Yeah.
And then another teen said, "When I'm riding home after group, it feels like I'm tired, but I'm happy. And it's almost like you get this warm, fuzzy feeling."
Yeah.
So I think, this group is a wonderful thing to be a part of. It has a really positive influence on family members. I'm consistently surprised that they show up every week. It's really an exciting thing to be a part of. And I hope that for you guys in the course of your work, you'll be able to use, some of the ideas that Leanne and her team have pulled together to create this terrific program.
Yeah.
And I'd be really happy to take any questions that anybody has at this time.
Great, thank you, Megan. So at this point, we'll take questions from the people participating. Just a reminder, you might be on mute, so we'll go ahead and take any questions.
Yeah.
This is Erin. Megan, could you talk a little bit about how you form the groups and how you decide how you're going to pick families to participate and really just the format of that?
Yeah, that's a great question. So we have an interest list. So clinicians in our clinic and then folks from out in the community will notify people who are running the group about a family's interest in the group. Then we contact the family and get, some kind of screener information for them. We want to make sure that the individual is able to participate in the group from a behavioral perspective. And that's been true for most of the people who have been interested in participating, but we do want to make sure that somebody's behavioral challenges are not so great that they would sort of limit the person's ability to participate and would take away from other people's opportunities. But really a big focus when we're considering participation in the group is what is the person's sort of cognitive and verbal ability level, and we try to stratify the groups by age and by their sort of intellectual ability level and verbal communication ability level. And the reason for that, it sounds sort of not very nice, especially because we do have a pretty significant focus on inclusion and so much of what happens here at the Waisman Center. But, the teens are really uniquely sensitive to being grouped with people who are different from them. Like they all want to be unique, but they want to be unique at the same time in the same way. And so for many of these young men and women, it's very, very hard to be grouped with somebody who they perceive as having like a significant intellectual disability as their peer, just because it's a sensitive time in their own identity development. And it's a pretty short group, being only 8 weeks, so we don't have a whole lot of time to work through those types of issues. So we have an older and younger groups for folks who have intellectual disability and folks who have normal range cognitive ability. And I just want to mention, too, that very often having a very heterogeneous group is challenging for parents because a parent of a child who has, 130 IQ but a lot of functional, sort of practical challenges may not feel comfortable bringing up some of the difficulties that they're experiencing around someone who has a nonverbal 17-year-old, maybe, oftentimes feeling that maybe their complaints or their concerns aren't as big a deal as the other family's experiencing. So we've found a lot of success this way.
Great. Thanks, Megan.
Are there any other questions?
Well, this is Ann, and I have a couple of questions, but I didn't want to take time if somebody else had another question. So, but I'll go ahead.
Yeah, I think we'll have you go ahead with your questions.
Okay. So actually, these are two different questions. And from my perspective, knowing both some of the issues that our transition grantees face as well as the program, the Transitioning Together program, I'm wondering, Megan, knowing that there's no research or necessarily evidence published or otherwise to back this up, but are there things that, as a clinician, you think would be particularly relevant to people who are working with groups of both adolescent and transitioning, we call them emerging adults, as well as their parents, who you talked about ASD with and without intellectual disabilities, but with other disabilities, because I know you work with other youth as well. But just thinking about sort of like the group cohesion that you talked about, and also the issues that parents might have in common. But are there things, I love the positivity and the idea of building on strengths, but just thinking about some of the other groups of children with special needs that we work with, if we were trying to adapt some of the principles of what you've learned in this program to other populations.
Yeah, I really feel like, so the positivity thing, I guess I feel like the positivity and the problem solving, and I suppose that probably most people would agree with this, apply to any population. I think that the differences come out when it's sort of like the content that the family brings. So we know that, kids who have a lot of externalizing behaviors, a lot of oppositional defiant disorders and ADHD that's severe and things like that, really benefit when people give them loads and loads and loads of positive comments instead of lots and lots of corrective statements, which they do need to hear. So, and then we all know that kind of like organized problem solving is really helpful. And so I think that that what I've, in talking with Leanne about her experiences, the challenges that she's had with other populations have occurred when she brought together people with autism spectrum disorder and who had developmental differences or other types of behavioral challenges who didn't have autism, because there was so much disconnect between the people, kind of the differences, the unusual challenges that people with autism spectrum disorders and their families had compared to people with other types of conditions. And so that kind of created some, not discord, but just, like difficulty among the families meshing together. But I think you could use these strategies with people with, any type of identified condition. And I don't know what the success would be with bringing kids who had different, or, families of who had...
Yeah, no, I was thinking more of a coherent group, or a group with...
Cohesive group, yeah.
Issues, but just maybe...
Some of the
maybe
other...
It would work with different ages or, early transition versus late transition kinds of issues.
So are you? I'm sorry. A little bit of the problem is I think it's kind of hard to the phone keeps on breaking up, so it's kind of hard to get the actual question out. But so you're talking about like things that you might focus on that would be relevant to people in early transition versus later transition. Is that?
It's assuming that maybe the group had a similar condition, and then I know a couple of our grantees have diabetes, and they're working with parents and youth with different special needs. They're assuming that it's similar cognitive and types of healthcare needs. Are there? I think you answered it really. The ideas of positivity and problem solving that could potentially be used with those groups are. Mm-hmm.
Yeah, and I think then there's the whole sort of content issue because there is content that's specific to autism for each group, and within the sort of obviously like the role of whoever was helping the family to share the content that was relevant to whatever the particular condition was that they were having. And then I can imagine that obviously the teen group also would probably have, a different shape because sort of many of the teens with other types of conditions might have different experiences with, success or challenges socially, and so
right with peers and other groups, yeah.
Yeah, like there may be many kids who don't really experience kind of social isolation, who have a different type of a condition.
There are those who do as well. And so I appreciate that. The second part of my question is a little bit related, but it is a little more specific to the clinical implementation. Mm-hmm. And I knowing that I know a lot about the challenges, but could you briefly summarize a couple of the challenges
Sure.
for implementing this type of a program as a clinical intervention?
Yeah. So we've had, a handful of different challenges that have come up in introducing these groups in our clinics. And, on reflecting on them, I don't know that the challenges that we've had are much different than you would have trying to implement any new manualized program in any clinical setting where it hadn't been run before. Unless you were really accustomed to doing a lot of groups, and this is sort of like our first shot in I think a pretty long time at doing a treatment program in our clinics. But some of the challenges that we've had have been with things like billing, where a lot of the focus in our treatment or our program here is on working with the parents, but because of the nature of billing practices and because of the service that we're providing, the teens have to be the identified patients, and so it's sort of outside of the scope of the Transitioning Together program as it was developed, but we need to come up with treatment goals for the teens and sort of actively work on those treatment goals, as opposed to making it like an exclusively sort of or putting so much focus on having a corrective social experience. We also need to incorporate some specific treatment objectives for the teens. So that's been kind of a big one. Another thing that has come up that in a number of different sort of administrative meetings have been the space that we're using and whether we can use sort of non-clinic space when the practical realities of the clinic is that we don't have like a room that will accommodate people in a comfortable way. So those have been a couple of the things that come up, and I feel like there have been a lot of people here who have worked really hard to get through those, but they're not that exciting, but they're they're things that we've had to work through. So yeah.
Thank you, because I know that, again, having been involved with both the research and the clinical implementation of this program, there's just different challenges, and we're looking at the outcomes to see when people are volunteer or in cases of getting research, sometimes getting paid to participate versus those who are paying to participate. So I just wanted to sort of bring that to the attention of the group, because I think sort of distilling the successful components and trying to apply those in different ways, to me, is kind of where I'm at.
Yeah, those are such important things for continuity and stability of the program. They might not be the fun part of it, but they're definitely the things that are going to allow you to do the fun part. So they're really important.
Great, thanks.